Hello, hello. Hope everyone's having a good day. We'll give everyone about 5 minutes to trickle in. And as you do, please put where you're tuning in from in the chat. And also, if this is your lunch break, what you're eating for lunch. I'm curious. I'm looking forward to some chicken parm after I finish the stream.
Oh, yeah.
What about the people on the West Coast? Should we put in what we're having for breakfast, maybe?
Breakfast, yeah. We should have a gimmick for them.
Okay.
What did you have, Evelyn?
So far, just coffee. So this is like an advertisement for Tim Hortons
Tim
coffee.
Hortons.
I'm coming from Canada.
Do they have those in Canada? I've never seen them in Canada. I'm joking.
I've only seen them in Canada.
I know.
I was about to explode with like patriotism and a whole spiel. So yes.
You can't throw a rock without hitting a Tim Hortons in Canada.
Yeah, pretty much. Yeah. Like Starbucks in many cities in the States.
Exactly.
Yeah.
Of course. I mean, is it run out of Canada?
It's in, I think it came from Seattle, actually.
Yeah.
I'm assuming it's everywhere. So
it is everywhere. Yeah. It is everywhere. Although I have a battle with my friends about, if they're going to be true patriots, they should actually go to Tim Hortons, but they don't necessarily listen to me.
I feel like a true American patriot goes Dunkin'.
Oh, yes. Yeah, you may have a point there. But in the hospital, in the children's hospital where I work, there's a Starbucks and a Tim Hortons. So it's very interesting to check out the people who stand in the two different lines. Anyway, just killing time.
Once again, if you're tuning in, I also, if you wouldn't mind for all the people tuning in, let us know kind of who you are. Are you a clinician, a parent of a child with OCD? Maybe you have OCD yourself, just so we get an idea of who's listening. Yeah, Dunkin' Donuts isn't a big thing down here in Florida where I am in now, but in the Northeast, that's the only thing available.
I haven't been in a Dunkin'. I used to love Dunkin' Donuts when I was in college, but I haven't been in a Dunkin' Donuts in a long time.
Tim Hortons is superior to Dunkin' Donuts, though. I've had it once, and the donuts are better. I'll admit.
Well, now they have what are they called? Beeb bits. So Justin Bieber has somehow gotten involved. So
what?
Instead of Timbits, those little mini things that you eat 4 of them, so it feels better than eating one donut. But
of course.
Yeah, but they're called Beeb bits. Anyway,
have you tried them?
No, I refuse, just on principle.
I'm right there with you, Ev.
Yeah.
You've got another person from Vancouver.
Oh, cool.
From Vancouver Island.
Nice. Vancouver Island's awesome.
Yeah.
Oh, now I see the comments.
I want to try a beep bit now. Are they just like flavored after his songs? Like, what's the connection?
It's really hard to tell. I think it's about advertisement, but
yeah, I mean, there are some
3 different flavors, and then there's a commercial about how he's brainstorming about the kind of Timbits,
I'm sure he's very invested in the product.
Very.
I don't know. I might age myself really quickly, but there's a TikTok star who has her own drink at Dunkin' Donuts as well.
Mm.
Can any of you know the TikTok star that I'm referring to?
The world has passed me by, Kyle.
What is this TikTok thing of which you speak?
Okay, I mean, I don't want to take for granted.
What?
All right, well.
Tim Biebs. Oh, they're called Tim
Biebs.
Sorry, I stand corrected, not Beeb Bits, Tim Biebs. Yeah, that sounds way more appropriate.
I like Beeb Bits, though.
So 2 people from Vancouver Island. I'm impressed.
Well,
we got a good mix of people here, too. Therapists and people coming in from medical centers. All right.
Parent of child with OCD and ulcerative colitis. Yes. Oh, blueberry muffin.
And eating blueberry muffin.
Yeah. But yeah, so much inflammatory bowel disease in families we see. It's striking. And eczema.
So we're 6 minutes past the hour now. Ooh, we're behind schedule. So I'm going to go ahead and get started. Hello, everyone. Again, thank you for joining us. As always, my name's Kyle. Just a little bit about myself. If you haven't tuned into the program yet, I am a sophomore at Yale studying neuroscience. Recently, I started getting involved in doing research at Yale, and I realized very quickly that reading research papers is difficult. And if you want to learn a lot about a big topic like OCD, there's a lot of different kind of niches within the literature, and it's basically impossible to be knowledgeable about everything. So I was really looking online for a program where I could just learn from the experts who have read all of the literature on a topic and get a good overview of it. And that's what this program is supposed to be, just a good summary of a topic within the OCD literature. As always, I'm joined by my co-host, John. John.
I'm John Abramowitz, and I also think that it's challenging to read research papers. I learned that a long time ago, but I still do it. And I am a researcher and clinician in North Carolina at the University of North Carolina, Chapel Hill, and I focus on OCD. And I love Kyle came to me several months ago now, 6 months ago, maybe longer than that, with the idea of let's kind of bridge this research practice gap and let's translate research into language that folks who are not big on reading research can understand and implement. And I thought it was a wonderful idea. So here I am as Kyle's sidekick. I'm happy to be here.
You're not a sidekick, John. Come on.
Whatever.
And as you can see, we have two guests. But before we get to the guests, I do have some general things to say. This live stream is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact a local clinician. The International OCD Foundation is not a crisis hotline and should not be used if you are in distress or feel unsafe. If you're in a crisis or are ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline at 800-273-8255. Also, we want to make sure that this is as safe a space as possible. As you guys probably have already seen, there is a comment section. We do encourage you to leave comments. We do want you to ask questions. There's not a lot of times when you can ask two experts in a field about the field that they're working on. But just please be kind and respectful in the comments. This is going to be broadcasted live. The comments are going to be able to be seen on social media platforms afterwards. So just be mindful of that and be mindful of where your words will eventually be seen. But without further ado, I'm now going to introduce our guest, starting with Evelyn Stewart. Dr. Evelyn Stewart is a professor in the Department of Psychiatry at the University of British Columbia and is a founding director of the Pediatric Obsessive Compulsive Disorder Clinic and Research Program at British Columbia Children and Women's Health Center. She is a clinical, genetic, and neuroscience researcher, as well as a child and adolescent psychiatrist. Evelyn, how are you doing?
Good. How are you? I'm always like, it's like exposure when I'm getting introduced anywhere where I have to kind of sit there and tolerate someone going on about me. But other than that, I'm great. I'm really happy to be here, actually.
There was a lot more that I could have said. I cut it short. I spared you.
Well, thank you. I owe you one. So.
And moving on to our second guest, Kyle Williams is the director of the Pandas Clinic in the OCD and Related Disorders program at Mass General Hospital and an instructor in psychiatry at Harvard Medical School in Boston. Dr. Williams' primary clinical and research interests involve the intersection of the brain and the immune system, and in particular, the psychiatric and behavioral consequences of these interactions. Kyle, how you doing?
Good. I think this is the first time I've been introduced by a Kyle. So I'm getting used to that.
Oh, nice.
Yeah.
I thought it was gonna be like good for our relationship.
Great. Yeah.
No, it's you're a Harvard guy though. It's gross.
Oh, okay. I see what's happening here.
Yeah. I am excited to be here. I'm glad. So I think that this topic is timely and has a lot of interest right now across a bunch of different domains, from parents talking about their kids, from people who have OCD themselves, thinking about is this something that we can consider with treatment, and how would we go about that, things like that. I think I think there's going to be a lot of growth and a lot of interest in this area in the next, hopefully, in the next 5 to 10 years.
It's certainly what I've heard just amongst the community, that inflammation is definitely a cool place to be checking out. I've seen it pop up in a lot of other psychiatric disorders just outside of OCD. But I got to tell you, when I was reading the papers that I wanted to kind of ground this discussion, I didn't understand a lick of it. So I think it will be good to get some general background in this live stream. And on that note, I wanted to ask the both of you, what is meant when we say neuroinflammation? Are we talking about particular parts of the brain, general inflammation? Like, what is it just generally?
Wow, you started with a stumper. Kyle, do you want to take that, or?
Yeah, I could try. So, but yeah. This answer may seem like starting with sort of a cop-out, but I don't think that there's actually consensus. So when we talk about inflammation, so a lot of when we talk about inflammation, we're talking about it assuming that it's always a negative thing, or it sounds like a negative thing. And in our, like, when we talk about, when I use the term peripheral inflammation, and Dr. Stewart as well, we're talking about inflammation outside of the brain or the central nervous system. So peripheral inflammation is when you have an infection, when you have, like when you cut yourself. And inflammation in that context actually promotes wound healing. It promotes clearing an infection. So inflammation is necessary there in order to, but it's a process that can damage cells and so it's something that has to be kept sort of under, used in specific occurrences, and then have a turn on and a turn off signal that works to prevent it from doing more damage in the body. And up until, I would say, the last decade, the immune system was thought not to be overly active in the brain under most circumstances. The brain was considered, and still is to some degree, but this term I think is a little bit outdated, an immune privileged organ, meaning that it was not sort of, the immune system did not surveil the brain in the same way that it sort of routinely checks in with the rest of the body. That at least was the thought. That's changed. But what has been interesting from a perspective for talking about inflammation in OCD and other psychiatric disorders is really the discovery that the brain has its own population of immune cells. And they look very similar to immune cells, a type of immune cell that's outside of the brain. But within the brain, they have a very different function. So in most circumstances, they are promoting sort of the correct maintenance and function of neurons and synapses. These are called microglia. This is a term that we'll probably talk about more as we go on.
Okay.
Under normal circumstances, microglia are, again, they're promoting neuronal development in utero. They're making sure that basically that neuronal synapse and neural communication is functioning as it should. They're kind of like housekeepers. Okay. If they then are challenged by an infection, or if there's a different sort of genetic state, if there's a sort of a disruption to them, they can create inflammatory molecules that can damage the cells around them. So part of what we're talking about neuroinflammation is usually we're talking about in some way the activation or the function of these microglial cells, and talking about are they aberrantly or more active in this brain region or in this psychiatric condition compared to someone who doesn't have that condition.
Mm-hmm. And what is it that tends to work them up? Why would they?
There's a lot of different things. So certainly they become active in neurodegenerative diseases. They become active in concussion. They become active in bacterial infections. There's some evidence also that they even become potentially overactive if you get an infection that's outside of the brain, but you have some of the circulating inflammatory factors in your body that usually are part of an infection. Your brain can respond, those cells can respond in a way to that sort of that peripheral inflammation, sometimes in a way that causes problems.
Yeah, and if I could jump in here, because I think what we're going to be talking about a little bit with some of these papers, and again, I agree, they're really complicated and dense to read. But I think part of the topic is beyond, what is neuroinflammation or what is inflammation, is how do we measure it? So for clinicians, for parents, so this is great in theory and, in mouse studies and all of that kind of thing, and showing this, and also in some human studies. But a lot of the work that's been done, or some of the work that's been done where they're able to actually show it in real time, is through imaging studies. But of course, those can be expensive as well. So, we've done a study looking at, is there an easier way to access a signal for inflammation? And is it, if you capture peripheral inflammation, so Kyle has just talked about peripheral inflammation, maybe separate from brain inflammation, and there's this, blood-brain barrier that theoretically, its job, excuse me, is to separate the peripheral stuff from the inside the brain stuff, because the brain's it's the most important organ. But anyway, what we've found is just collecting saliva samples, so getting people to drool into a little beaker thing, we've been able to pick up on peripheral inflammatory markers. So I think that's something we'll talk about too. And it's kind of interesting, what we were able to find is that there was, although, looking at the inflammatory markers that are in your spit, effectively, it didn't differentiate kids without OCD and kids with OCD, but it was a marker for severity. And why that's kind of cool is that seems to be the case in other disorders too, where there's sort of inflammatory markers seem to be correlated. It can't tell you, oh, this person you can't look at a bunch of saliva samples and say, this person has depression, this person has psychosis, this person has OCD, and this person has none of them. But with the level of inflammatory markers that are just going around either in your blood, in your cerebral spinal fluid, so the thing your brain is kind of hanging out in, or in your spit, but the level of those markers seems to correlate with the more severe your illness is. So anyway.
And those markers, is the idea that the microglia are producing kind of the inflammatory molecules, and then they somehow sink into the saliva and you can measure them there, or?
Not so much. So I think the microglia are really important inside the brain. It's more that the system is turned on. So exactly like Kyle was saying, this is inflammation is not meant to be all bad, or having an immune system is not bad. You need to have something in your body, watching out for coronavirus, or, something bad that's coming in, or, a bad chicken that you've eaten, that sort of thing. So just kind of monitoring. And then there can be a signal to go and sort of attack that outsider. The problem that comes into play is when it's a false signal. And this is, I think, what we see with a lot of families where, just speaking broadly, there's sort of a vulnerability to overreact, to misinterpret a signal. So I think the saliva inflammatory markers, it was the first, I think, study that's been done in OCD, to my knowledge, in kids. And we were just trying to see, given that theoretically they're two different systems, right, in the brain, neuroinflammation, and in the periphery, is there anything we can do, just taking a sample from the periphery, that might signal what's going on in the brain? And it does seem that there is. So Kyle, you could probably give a more sophisticated answer, but I don't have a PhD in this. I'm just kind of learning as I go, but I think it's more or less a signal of how your body, the state your body is in. Yeah. In terms of like defense mode. Whoa, there's something going on here that's wrong. Send out the troops, kind of thing.
Yeah. I think one thing. So these microglia are, again, they're similar to other immune cells that you have in your body. So they're not in any way identical, but they perform a really similar immune function at times. So there's some kind of I think similarity between if your peripheral immune system becomes activated, do microglia become activated or do something that you don't want them to in a similar manner in certain, I think, vulnerable individuals. Because I think the other thing to remember is that the vast majority of folks, even folks with psychiatric conditions, will have the general, infections, colds, flus, etc., and they won't be significantly worse for that. It doesn't significantly alter the course of their illness. Sometimes it does in kind of short bursts. It makes, psychiatric symptoms. Tic disorders is a great example of, we know that outside of the Panzer Pandas kind of realm, and we can talk about that later on, folks that have tic disorders, their tics usually get worse if they've had an upper respiratory infection recently. We don't know exactly what is moderating that, but there's something to it. And one reason why we focus on microglia, aside from the fact that they're kind of the primary immune cell in the brain, is that probably 10 years ago now, actually maybe it's even more, 15 years ago, there's a group in Utah, the University of Utah, former Nobel Prize winner Mario Capecchi. His laboratory was basically looking at knocking different genes out of mice. So we're going to talk about mice here for a second, which I know is not exactly the same, but it's useful to talk about in a little bit. They're knocking genes out, meaning that you can selectively remove a certain gene from a mouse's genome, and then you can look at, is their behavior different? Is their neurodevelopment different? Is their skeleton different? What they found from these mice was that largely the brain developed what they could see, that grossly the brain developed the same, the skeleton developed the same. These mice groomed the vast majority of hair off their body. So they groomed themselves just to a degree that they basically groomed the hair off of themselves. They groomed, litter mates, I think. But this was seen as basically, wait a minute, is this an animal model of obsessive compulsive behavior or grooming? Can we use this animal as sort of to test strategies or treatments for OCD? What they found out later was that when they removed that gene, they ended up decreasing or disrupting the microglial population in the brain primarily. So they affected specifically this immune cell in the brain.
Mm-hmm.
They did not have the full complement of those immune cells, and they developed this OCD related behavior. Then they were able to actually treat that behavior with an SSRI. So there was some modulation of it, but they were secondarily able to treat that behavior by giving the mice a bone marrow transplant. And I'm not advocating this for anybody, by the way. I'm just talking about the mechanism of this paper. They were able to give them basically bone marrow from normal, non-knockout mice. And in doing so, they're giving them this microglial cell back that they had sort of taken. The microglia essentially migrated back to the brain, and the behavior stopped in the majority of these animals. So I don't want to overemphasize how important these are because it's mice again, but this was really the beginning kind of the focus on microglia and their contribution potentially to OCD, to severity, or to the kind of generation of OCD behaviors in humans.
Mm-hmm. I have a question, if I can jump in. The inflammation and some of the stuff that you were talking about, Evelyn, with respect to association with OCD severity. Does inflammation, is that something that's pretty constant over time, or is that like if you measure it one day or even an hour by hour, does it change?
Such an awesome question. So it depends. This is going to be a frustrating seminar in terms of tolerating uncertainty, right? Because so you see Kyle and I are kind of saying, well, it's not. So it's a very complicated field, and it's shifting and growing. So there's some of these cells, sort of let's say that COX-1, for example, this thing that's in one of those papers, where it constitutively, meaning it does its thing. Regardless of what's going on the outside, it just expresses these proteins that are related. But COX-2 which is kind of, I'm bringing it up because it's related to this medication we're talking about, it's reactive. So how active it is or how much it expresses protein can be triggered. So it can go from like doing almost nothing to being super active. So it definitely changes over time. And that also influences, so, the state that you're in, hypothetically, if your full body's, full on and in reactive mode, you can have a lot more expression of those proteins. Did that answer?
Definitely, yeah, that's helpful.
Yeah. So it's really, it changes so quickly, and that's also what makes it hard to research as well. So if you're looking for these markers, you have to be really cautious because lots of things can in fact impact a person's inflammatory state. So we have to be, super cautious to not just say, well, therefore we've proven everything. So it's a very, well, humans and biology is very interconnected. It needs to be, but it can change over time. So
cool.
And just sorry to add to what Kyle was saying as well, like even in OCD, we know, like, well, you guys, some of you who live with OCD or have kids with OCD or work with OCD in your clinics will know this just anecdotally. When people are more tired, when they've been sick, those are times when you're sort of more vulnerable, right? And then there is this sort of increasing of severity. So all these things tie together. It's not one or the other. It's not, do we do ERP or do we do antibiotics? I think all of these pieces come together.
Yeah, I think if I can jump in too, that's really where the promise of this, of looking at this, I think lies, right? Because does inflammation or autoimmunity or anything, does it contribute to the generation of OCD behaviors or et cetera? That's an academic argument unless we can actually use it for treatment, right? So it's far less interesting unless we can harness it in a way that, we can identify certain people that maybe either, again, we identify someone who will benefit from some type of anti-inflammatory treatment compared to someone else. We still, the two things that are not for lack of trying, but are still frustrating, I think, as people who treat OCD, is that at the end of the day, I can't tell anyone why they developed OCD. If it's genetic, if it's inflammatory, if it's from an infection, we have our hunches, but can I actually point to something on a laboratory test or something and I say, this definitively proves your OCD is due to this infection, or nothing so far, right? And that's actually a bit different from, even genetically, it's different for, like, we have risk factor genes for a lot of psychiatric disorders now. We don't, Evelyn, tell me if I'm wrong on this. Last I checked, there's not a consensus hopefully it's getting close, but there's not a gene so far that everybody agrees that's been identified as potentially a risk factor for developing OCD.
So interestingly enough, after like a decade of kind of being, well, I was more centrally involved with genetics and then more peripherally because I kind of gave up hope. There's a paper in Press now where they finally have a significant association with a SNP in a gene. But again, it doesn't have a huge effect size, which means that, sure, it's a piece of the puzzle. So we know this, I don't need to argue about it. It's a piece of the puzzle, but just like many things are a piece of the puzzle. And I think what is clear as well is that inflammation is a piece of the puzzle in OCD. And I know there's been the thing about PANS or not PANS. Do you believe in PANS? And anytime we're talking about, do you believe in something, it's asking about a leap of faith. So I'd rather just kind of avoid that whole thing. And how about we accept that there's signals, right? Yeah. And within, I would say, what I would love one day would be, if we could have this way of, with the individuals with whom we work, to be able to get a feel for what are the things that are going to get in the way of treatment? What are the things that are going to be helpful? Like for this individual, is there kind of family pieces that would be helped to hone in on? In this individual, is there sort of a signal for this reactivity of inflammation? Or for this individual, is there more of a glutamatergic piece? Or is there, is there distress tolerance or that kind of thing? So we're kind of bringing together the worlds rather than saying, no, you've got this kind of OCD, you go to this person, or you got this kind, you're going to go to this person. More the recognition that we need to consider all the tools we have. And I think one of the things that's becoming clearer is there may be a role for anti-inflammatories in OCD, which is really exciting, because for so long I'd have families who would come to me and say, okay, Dr. Stewart, you know, it's been a year or two since I saw you. What do you have for me? You know, what's the new thing? And it's been, you know, it's hard when you're, you know, we know the field's working hard. So we have had some increases in knowledge about, you know, adding to exposure response prevention, which I would say is the gold standard, but looking at approaches like ACT, acceptance commitment therapy, looking at inhibitory learning, which is, you know, can be a piece of that. That's excellent. But on the medication side, adding to what we know about SSRIs and atypicals and maybe some glutamatergic agents. Some people, I think there's signaling that there may be hope for anti-inflammatories if we can get people into our trials, Kyle.
Yeah, I definitely agree. And it also, what's interesting too, is that it also highlights a problem that we have in psychiatry and how we train people that we need to address, because there's a lot of, and psychology as well would be wonderful. You know, I think on the psychiatry side, we right now, you know, on the research side, you know, particularly if you think about autism, we talk a lot about sort of immune activation, maternal immune activation, and autism as a risk for you know, offspring with autism, or you know, we're talking about inflammation and OCD, but these same theories exist and are valid and testable in depression, inflammatory models of depression, inflammatory models of bipolar and schizophrenia and things like that. But psychiatrists right now are really not trained in the use of anti-inflammatory medications, right? Treatments and things like that. And so I think there needs to be a shift in how we educate people as well to recognize these. And that hopefully will happen after we have a more tangible, like we have a more testable ability to say, if someone comes in and we want to get an answer regarding, is an anti-inflammatory going to be helpful for them? We have to have a way to sort of, that's beyond just sort of like throwing medications out there. We have to have a way to, I think, to try to predict who they're going to be helpful for. And when we have that, maybe then I think my hope is that psychiatry, child psychiatrists, adult psychiatrists in the future are going to train in this, right? We're going to have sort of, it may be a subspecialization of psychiatry, but we have to have people that can recognize and treat these and use these therapies.
Yeah. So again, we're repeating ourselves here, but I just think it's so important. It's not an either or, but if there does seem to be an inflammatory component, it's really important to respond to that. But it doesn't mean you shouldn't try the other things as well, because I think that's where there can be real problems. Yeah. Sorry, Kyle.
No, I agree.
Not getting any. Yeah. Or I was actually saying sorry to the other. I'm sorry to both Kyles. But okay, Kyle's not getting word in edgewise yet.
I think it's a good idea, or it's certainly good to just understand that it's one piece of the puzzle. But I'm trying to wrap my head around kind of what the general feeling is as to what piece of the puzzle it may be. Because that study that you mentioned, older Kyle, sorry.
Did you hear what just happened?
I didn't mean to say
ouch. I mean, Kyle, I knew you were thinking it, but now you said it on the internet. And,
older Kyle. About the mice, it sounded like inflammation there. You know, you could plausibly make the leap that led to the genesis of OCD-like symptoms, while in Evelyn's study, where she talked about kind of the saliva, it sounds like inflammation seemed to kind of give way to a gradient of severity of symptoms. Like the more inflammation, it seems like the more severe the symptoms were. So like, how do you guys think inflammation fits in? Do people think that it may be like causal, or it's no one knows really?
I'll give the more superficial answer, which you guys are probably picking up on the pattern here. I give my, I do a lot of reading of these things, but I'm not an expert. So I have this, and I'm a child psychiatrist after all. So you got to cut me a little slack, but I have a way of trying to simplify things, like big picture. And then Kyle Williams, old Kyle.
You're an
That's
old
gonna
guy.
stick. That's gonna stick.
I know.
Old
I'm
Kyle
sorry.
to get more into
Oh,
the details. So I would say, like from 30,000 feet,
Mhm.
my answer once again is not one or the other.
Yeah.
So these things are interconnected, right? Your body has feedback loops all the time. So if we're trying to figure out cause and effect, I think we know like you have to determine all these different things, but in reality, all this stuff happens so quickly. So I kind of think of it, your system revving up or revving down, and it can be a bit of a chicken and an egg scenario.
Mhm.
So that's my sense. So the takeaway isn't that someone's body is overreacted to inflammation, and therefore it creates neuroinflammation, therefore it creates OCD, and that's it. I think there's also the thing of there's the OCD going on, which is a stressor, which can be a trigger. So it's more circular than saying, oh, there's this and this. But even with when you have a circle going on, if you're able to slow something down, wherever part of the cycle it is, tone things down, that can be helpful.
The thought is or there's at least a line of thinking that the psychological stressor of OCD could possibly trigger this kind of immune response.
Well, yeah. I mean, so I think we don't want to understate the importance of psychological stress. I mean, that's of all the kinds of stress you can have, that's one of the most important kinds. So if you have cancer, if you have any disorder where it's keeping you from going to your job, keeping you from being able to change your baby's diapers, that's probably one of the that's massive stress. If you got these thoughts coming into your head that are totally foreign to who you think you are, gosh, I can't think of anything much more stressful. So yeah, so what I would love people who are listening here to take away with isn't that, oh, inflammation is the thing and that's it, and let's not pay attention to anything else. It's this stuff is very interconnected, and I think there's no time in the past as much as now where we're needing to recognize our gang, old John or new John, I don't know, and old Evelyn, new Evelyn, old Kyle. Well, we know it's old. We have to be working together, and it's not the either or here, right? So
yeah, I agree. I think so. And if I'll try to hit the high points here. So Kyle, I think it's a really good question. Sometimes we're talking about did inflammation or a difference in the immune system cause this disorder? Was this a result of abnormal immune function versus this started for a different reason or an additive reason, and then abnormal immune function worsens, or in the absence of abnormal immune function, things are better, things are fine. Does that make sense? It's sort of like there are models of diabetes, right? Obviously, type 1 diabetes is an autoimmune disease. If someone presents to you who already has diabetes and you treat them with anti-inflammatories, you won't do anything for them to reverse their diabetes, right? You have to follow that with a therapy that sort of replenishes something that happened to them. And so you will not if you use that evidence to try to trace back the origins of, it would lead you to the wrong conclusion about sort of what is causing what. So right now we have a really hard time telling the causative aspects from the sort of correlates of make things getting better and things getting worse, because a lot of those folks potentially look like, in the absence of testing, those populations of people may overlap. They may overlap in similar presentation and may overlap in response to therapies too, right? So, Chris Pittenger and some of the work that we were doing at Yale previously was trying to look for an autoimmune antibody in kids with pandas. This also gives you just a couple minutes to talk about pandas too, which I love. So to talk about at least, but so we were looking for an antibody that we thought was causative that was interfering with part of the basal ganglia, part of the this area of the brain that we think is involved in OCD, and that antibody was like one of the terms that we use is so necessary and sufficient. It was necessary to cause the behavior of having that antibody, and it was sufficient by itself to sort of generate these behaviors. And so in that case, you could say this: if you didn't have this antibody, you may not have OCD, right? And that may be a very small subset of people who actually have OCD or pandas, whereas the wider, more common aspect is people who have some genetic vulnerability to develop obsessive compulsive disorder, who also then have some type of abnormal immune function that then drives the expression of that behavior, or something happening in the brain that makes that OCD more likely, right? Because if we look at families of people with either pandas or even with OCD, it seems like they're more enriched for autoimmune conditions, right? But that is also true in other disorders too. It's not just OCD. So schizophrenia, depression, other conditions too have higher rates of family members with autoimmune conditions, and then also higher rates of family members with those similar or psychiatric conditions too. So we're talking about some of these additive mechanisms, and we're trying to, I think, find technologies and find reliable markers to differentiate these populations, because once we have that, we can separate those populations and look at the different response to therapies in a way that we don't mix things up. If, for example, IVIG, this trial that we've done, this therapy that we've done for pandas, if we don't enroll the right kids with pandas, or if we don't, or even with potentially with kids with this antibody, IVIG may look like it doesn't work. And maybe IVIG doesn't work, right? I'm not saying that that's true, but I'm saying that you can't evaluate that really correctly until you enroll the right population, and that is based on identifying the right population.
So it's weird. Go ahead.
No, go ahead, Evan.
I was going to digress a bit, so old John, you go ahead.
I was just going to say what you're saying, Kyle, makes a lot of sense in terms of that this doesn't seem like it's specific to just OCD, that we're seeing this in different problems too. And then that goes back to link that back to Evelyn, what you were saying before about how, there's chicken and egg, and maybe the causal arrow goes both ways, because the stress, OCD is very stressful, but so is depression, and so is schizophrenia, and so are eating disorders and other things too. And so, as much as it could, we want to think about, that it's the inflammation that's causing the psychiatric symptoms. It could also be that the stress of any of these kinds of disorders is also playing a role in the inflammation, which is why we're seeing that in different problems, not just OCD.
But I totally agree. But I would say, as someone who I've changed over time. One of the reasons I do OCD and actually didn't do pediatric neurology and went into psychiatry instead was this story of pandas. And I was, how intriguing. Are you kidding me? This is so neat. So I got very excited and then very kind of not and da-da-da. So I've landed kind of somewhere in the middle. So I think, having seen lots of these kids with OCD, there really does seem to be something different. If it's a certain chunk of these kids and it's qualitatively different. So the extremity of like how sick they get, how like everything falls apart in the household. And then you see them a month later and it's like, like nothing, like no evidence of anything. Whereas with 90% of the kids who I see with OCD, 95, 90, there's some lingering symptoms. We're trying to squash those, and da-da-da. But so and I guess how I understand this is for those individuals, if you're looking at like, once you have your cup filled, you got OCD. I think for those individuals, it's like their cup is mainly filled with those immune reactivity, inflammatory, all that piece, so they just need a little bit of extra, which might be psychological stress, or it could be these other things to overfill. Whereas in other individuals, it could be, their cups, you get some families where, gosh, everyone's got OCD, so you have that and the environmental influences. So their cup is filled with these other factors. So that's my simplistic way of understanding it. But there really is, I would say, this distinct subgroup, not saying that there's not other pieces. So it's not totally different, but it really seems quite different. But I would say even to those folks, if there's any of those folks here, don't give up on ERP and the other pieces, right? Because I think there's been some misinformation out there about, where I've had families say, nope, my kid has pandas. I don't want to hear anything about anything else. Just want IVIG. Well, I don't think there's still that other part of the cup filled with those other pieces.
Mm-hmm. Yeah, I agree. And I think too, I think it's also helpful to say out loud, and I'm going to editorialize for a moment. I think the world has not been fair or kind to the concept of pans and pandas, nor has psychiatry, nor has, I think, medicine in general. There was sort of this expectation that when the entire sort of mechanism for pans or pandas was not figured out, then it was like, oh, well, this can't exist. And the reality is that it's just in good company with every other psychiatric or neurological disorder that we don't have worked out, of which there are legion, right? I mean, that's that we don't have the mechanisms worked out for any, or not any, majority of psychiatric conditions. And pandas is not an exception to that. So because what we're talking about now is inflammation and OCD as sort of a viable, both, etiology, treatment, biomarker. Panzer Pandas is probably one entry ramp onto that highway, right? At least that's how I view it.
Yeah.
And so it doesn't mean that all OCD is Panzer Pandas. It doesn't mean that you would rather have Panzer Pandas than pediatric OCD either. It's not, none of these are a picnic, and we sympathize with everybody who's going through any of these disorders, or as a child who's going through any of these things. But I think that the sort of scientific community, the medical community, has to step back and say we owe it to reevaluate these associations, particularly, and I won't go too much on the soapbox here, but COVID, we from the get-go have accepted that COVID can cause lasting neuropsychiatric sequela, right? You would talk to anyone and say, hey, can this infection, COVID, cause a lasting neuropsychiatric or neurological disorder? Everyone said, yeah, I think so. So we've been saying that in the Panzer Pandas realm for, like 20 years.
Yeah, right.
Practically, like, I don't know, this seems like fringe, So it's not, but there is a long ways to go in showing how these things happen and how to treat them and how to be reliable in the diagnosis, because we don't want to paint everything with the same brush, either for treatment or diagnosis. But I think we owe it, as people who wanted to better the lives of folks with OCD and treat kids and adults with these conditions, we owe it to take a serious look at these things again, despite what's happened in the past.
That's a great analogy to COVID.
Yeah. Kyle, I'm sorry for my skepticism that is step over time.
I'm as skeptic as
John, this is your moment.
I just want to get it right. And I think it makes sense to be skeptical, right? Like we want to make sure we do not want to give the wrong treatments to anybody. And we don't want to miss giving some things to someone that, right? So a high degree of skepticism, I think, is appropriate in all of these things. What I get, and you've never had anything like this, but what I get upset about sometimes, or what I'm frustrated by, is a better way to say it, is people say like, nah, I don't believe in that. Or it's sort of well, okay, all right.
That's what I was referring to too. Like people will say, do you believe in pandas or not? When people come up to me at a conference or whatever, I don't like that question.
No,
like,
right. Yeah.
They don't say, do you believe OCD is fully due to the, so
right.
I think I totally agree with you, Kyle. And I think it's sort of sad that it needed, the COVID piece needed to come out so thoroughly, and that use of, looking at inflammation and depression, where it's accepted now, right? That there's a role with depression and, psychosis and these other things. It's unfortunate that in the OCD world, I think there is this group where it's particularly profound, those inflammatory effects, and people have been talking about it, and it's been politicized instead of like just kind of using it as a piece of the puzzle. So, but at least we're now at an era where I think even John, right? You've been, I'm picking on you a little bit. I'm just teasing.
Go for it.
Yeah. Even John, how's he going to say it's impossible there's any role? He's not
so I've never said that, but as a scientist, what we want to do is we want to be skeptical and dispassionate. And when we do that and we do really rigorous research, then if stuff shows up and stands that test, then we have a more definitive way of saying, yeah, this is probably true. I've always been open-minded about just doing good research to figure this stuff out.
I haven't actually heard if you've said anything about pandas before.
I don't know. I
remember you talked about genetics though, way back.
I've definitely talked about genetics. Yeah, we can.
And but now look, there's a gene, but still,
Well, but there's not a gene. We're never gonna have like a genetic test where you spit and
don't get John started.
It's impressive.
Don't get me started about genetics. But no, but I mean that's one of the things I'm fascinated about this, to just learn about all this. I just don't work a lot in this area, but I'm learning.
One of the things too that I think has changed that we should just touch on for a minute too is that there's a model of psychosis and schizophrenia called NMDA receptor encephalitis or autoimmuneencephalitis. So people have heard of Brain on Fire, or there was a Netflix series and it's a book now too. It's a brain condition that is due to autoimmunity. So you're creating an antibody against your own a receptor on your neurons, and that antibody basically disrupts that neuronal communication in a way that produces profound psychosis, along with other things as well. But what is terrifying, I think, about that, so it's fantastic and it's incredibly interesting that this has been identified, but people lived and died for decades, right, with an autoimmune condition that looked like psychosis, and they never improved from the traditional therapies because they were never recognized as having an autoimmune disorder. And now, if you test for that and you recognize that condition exists, you can give the appropriate treatment. It's still difficult to treat, but that antibody tells you can learn something about the biology of psychosis from that antibody. And so I've always hoped that pandas can also inform on OCD as a whole.
Yes.
If we can understand it in a way that we understand, okay, maybe it's going to be driven by an autoimmune antibody. Maybe it's going to be more complicated than that. But is there a specific subtype that we can say, hey, it looks like this is malfunctioning, and maybe that also is applicable to OCD in general, in a way that can extend beyond.
I totally agree with that. And I guess what's jumping to mind is, John, when you were just talking about, research and confirming things, an approach sometimes we will take is we will look for the extreme ends, right, of a pathology. So that can give some influence. So I think with this group, how I would envision this is this group, PANS, whatever you want to call it, they're sort of the extreme end in terms of the role of immunity and that kind of thing. So if you study the extremes, it can help because it may have a role in the non-extreme parts too.
Mm-hmm. I've been looking at the public comments, and it seems like a lot of people are interested in the treatment, and I'm also interested in kind of the treatment implications of all of this. So I was wondering if you guys could just give a brief overview of how we take this knowledge that there may be, or that there probably is some role of inflammation, and what treatment methods have been introduced, and what kind of the studies look like for, I think you said like IVIG antibodies. I don't know exactly how those work or anything.
Yeah, can I jump on this for a minute, Evelyn?
Yeah.
And why don't I handle IVIG and you can talk about NSAIDs?
Yeah.
Okay.
I'm sorry, what?
So I would say that the treatment studies have been mixed. Some of them. We want to have, if we're gonna use a therapy for someone, we want to try to approach it with the most rigorous and unbiased test, right? Study. And that usually is a blinded sort of like nobody knows what the patient is getting, right? And then we evaluate it at the end. And so we try to minimize the bias. And the IVIG trials that have used that approach are sort of split as to whether or not IVIG is helpful. One of them said, yes, it certainly is. The other one, the picture was a bit more mixed than that. So the reality may be somewhere in between on that. And IVIG is an infusion of antibodies from other folks. It is not something that it's safe and it's typically relatively well tolerated. It's expensive. It's usually not covered by insurance carriers. And it's not something you want to do, I feel like, unless other things haven't worked, or there is such a clear indication of this type of autoimmune condition driving your panda symptoms. And we don't know how to, I think we're still learning how to test for that.
And would you even say, like, let's say you don't know for sure if someone has pandas, do you just give it, would it be possible to have it for anyone with OCD? Just give them these IVIG antibodies?
So if the science matures to a point that we understand that both pandas and a subset of adult OCD is driven by immune dysfunction, and that immune dysfunction is specifically helped by IVIG or made better by IVIG, and maybe not by other things that are less invasive than IVIG or easier or less expensive, more readily available, then yes, maybe. But I'm throwing a ton of comments.
Right now, it's not.
So that might be something down the road. I think there's a lot of work that needs to be done, but it's not impossible.
Okay. And I mean, when I was reading these reviews, they also spoke about just kind of other non-specific anti-inflammatory agents like ibuprofen or NAC. So are there other kind of anti-inflammatory therapies that have been studied, and what do those studies look like?
Yeah. So we are doing a study of non-steroidal anti-inflammatories in pandas now. And I'll let Dr. Stewart talk about the studies that they're doing too for pediatric OCD. But and let me also just put a warning out there: don't do this on your own. Okay, please don't use over-the-counter anti-inflammatories to treat your OCD, because even though they're over-the-counter, there's still certainly there are important things that you have to use in conjunction with a medical provider. So don't do this independently. We have seen what we believe is a signal there, some potential to treat OCD symptoms from anti-inflammatory medications like non-steroidal anti-inflammatories. The question is, who does it work for? How long can we do it safely? And is that sort of a permanent solution, or is that a stopgap measure to figuring out something else that's driving their symptoms?
Mm-hmm. And Evelyn?
Yes. Sorry, my computer's acting up. Okay, I can't see you guys, but I assume you can hear me?
Yeah.
Okay. So around the anti-inflammatories, we're doing a study as well in Vancouver. But again, with this notion of, many roads to Rome, and there's many different factors involved with OCD, we haven't limited it to Pandas. So any kids with OCD. And what we're using is celecoxib, or Celebrex is the other name it's known for. So in Canada, anyway, you need a prescription for that. So the reason we chose that one over some other anti-inflammatories is because of its mechanism of action. So it seems to be more specific in terms of that brain activity, in terms of COX-2. But again, I think if you have OCD, the gold standard treatment is exposure and response prevention. And in many cases, that's not helpful, or people aren't able to make a lot of headway, and then medications can be really helpful. So I will say, how we're using anti-inflammatories here in our trial is as addition to treatment as usual. And I thought it would be so easy to recruit for this study. I thought it'd be just like easy as can be. And we haven't recruited one kid yet. So it's a shock to me, but this is the kind of work that really, really needs to be done. So.
Well, we are at 1 o'clock, although this has been the most interesting discussion I've ever tried to follow. I don't think I followed it completely. I want to thank.
No, I'm just kidding.
Well, yeah, you're old, I get.
That's right. Yeah, this is every day for me. Yeah.
I want to thank both you, older Kyle and Evelyn, for participating with us. This has been super fun. Thank you for everyone for tuning in. And I I'm sorry that I didn't get to everyone's questions. There was just a lot going on, and I was trying to focus on a lot of things, and I got overwhelmed. But thank you. I hope everyone who listened had a great time, and I'll see you next month.
Yeah, thanks a lot, guys. I learned a lot.
I'm sorry, go ahead, John. I just want to.
No, I was going to say no. Thanks for explaining this stuff. I learned a lot. I don't follow this part of the research as closely, and so it's really cool to hear it from you guys, especially.
Even us old dogs can learn new tricks, eh?
Even you old dog, even you Canadians.
Yeah. See.
We are. So one, I'm really glad that IOCDF is doing this. I don't thank you, Kyle and John, for doing this too. So we are recruiting for some studies of adults with OCD in Boston, and some pandas as well. And you can email us at ng. It's all one word, NGHPANDAS@partners.org. And I'm also I can't say that I'll respond, that I have time to respond, but I'm also very interested in hearing people's stories about autoimmune conditions they have along with their OCD, like psoriatic arthritis, or treatments for autoimmune conditions that have made their OCD better. Ehlers-Danlos, psoriatic arthritis, PFAPA, some other things. So feel free to shoot us an email and let us know kind of what your experience has been.
Can folks participate remotely from all over the place, or they have to be in Boston?
They have to be in Boston for, so we're doing an imaging study for adults with OCD to try to, we're doing a PET study to look for microglial activation in adults with OCD. And then we're doing an imaging study for kids with pandas. That's an MRI, it's not a PET study.
So they got to be there. Cool.
Yeah.
And for the, I see there's a question in the comments. So sadly, yeah, you need to be in Canada to be part of our study. I've checked that out. So it's fussy Canadians. Darn Health Canada.
We love Canada.
Oh, it's important. Well, thanks everyone for joining.
Thank you.